هنبدأ إن شاء الله. هنبدأ إن شاء الله جلسة الكيس برزنتيشن جاستروانتستينال اند ابدومينال كيسز. دكتورة ماريز عوض الله ودكتورة داليا منير ودكتور طبعا دكتور هيثم عبد الغفار.
دكتور عماد طبعا هنبدا اول سيشن باذن الله. فيرست سبيكر دكتور عماد شرف. طيب first speaker Professor Dr. Emad Elshorbagy. His presentation about a rare case of primary hepatic lymphoma combined with hepatitis C virus infection developed hepatocellular carcinoma. تفضل دكتور عماد.
السلام عليكم. My case presentation today is a rare case. It is a primary hepatic lymphoma combined with hepatitis C virus infection developed HCC. A 70-year-old Japanese man was hospitalized in National Cancer Center Hospital, Japan, for anorexia, vomiting, right upper quadrant abdominal tenderness. The patient has no complaint of fever or significant weight loss. He didn't have history of smoking, alcohol, or drug abuse. He had a past history of hypertension and gout. Physical examination revealed no abdominal finding except for tenderness, firm, irregular, enlarged liver, and shifting dullness on percussion. There was palpable superficial inguinal lymphadenopathy, and you can search for superficial inguinal lymphadenopathy. He had hepatosplenomegaly. Later, patient developed low back pain, leukorrhea, and jaundice. This is laboratory investigation. You can look for the albumin is decreased, while the bilirubin is very high, and also the liver function test is while alpha-fetoprotein, it is not a diagnostic value, just suspicious 224, but not diagnostic for HCC, and also viral marker, tumor marker is high. Other laboratory investigations about YBCs, it is low, 5,000, and the parameter of coagulation were reduced. Acidic fluid histology detected elevated neutrophil and lymphocyte and monocyte. This is clinical data. Diagnostic imaging modalities starting by ultrasonography, and you can see this is this is free fluid, this is the ascites, and the liver is looks like irregularity and heterogeneous and involved by ill-defined masses, while when we shift to CT scan without contrast, non-enhanced CT scan, we can see multiple hypodense lesions, irregular variable sized and involved both lobes, and you can look for another small bulging from the surface of the liver with hypervasculature or hyperdensity, and this is hypodense multiple focal lesion involved with both liver lobes. Shift to arterial phase in triphasic CT scan, and you can see the both liver lobe is infiltrated by different pattern, variable size, different enhancement. This is more enhanced, less enhanced, and this look like a cystic breakdown area in segment 4. Many pattern, you can see this one, the less enhanced area, and some areas is not enhanced at all. This is mean pattern, not characteristic for anything, but anyone do this one, you can diagnose as a hyper enhanced or hypervasculature of metastatic deposit. This is one possibility. Now we shift to portal phase, and in portal phase it is large, look like cystic breakdown, and like actually there is washout. Mainly, most of lesion is washed out, while one is cystic in both arterial non-enhanced, arterial and portal phases, and this is one is show marginal enhancement, and this is one is show also marginal enhancement, and other show washout. This is another level, and you can see the part of the liver is the delayed phase, and one is heterogeneous and is still within this lesion area also breakdown and more enhancement. Also, this is another image. It is hazy actually, but anyhow, we can see also different enhancement. What we can suspect as this pattern, it is not take the character of HCC mainly, and when you see different, actually metastatic deposit in multiple abscesses, this is a multiplicity, this is the most common lesions, you can see the same pattern. It is, if it is metastatic deposit or multiple abscesses, margin enhancement, and it is cystic breakdown, all. But here we can see different things. Must you think about more than one pathology in this lesion? This is the concentration, and from this case, you can learn this point when we discuss how can to describe the pattern of trifid CT in this case. No characteristic pattern. You cannot give a final diagnosis, not metastasis, not multiple abscesses, not clear HCC. This is in your thinking. Anyhow, imaging modalities cannot help you for the diagnosis. You need to do pathology. The pathological finding, where in the clinical data we see inguinal lymph node. Actually, we take biopsy from this inguinal lymph node and demonstrate diffuse large cell type B cell lymphoma with malignant infiltration. There was no evidence of biliary or pancreatic disease. The cells were positive, and the proliferation index was very high, positive in 90% of cells, establishing of diagnosis of diffuse large B cell lymphoma, according to the WHO classification. Actually, postpartum and autopsy done, you can see macroscopic picture, the liver parenchyma show prominent enhanced grayish portal tracts. That is the pathology, and the tumorous variable size nodules region involving both lobes. And you can see this is the autopsy after you can see the liver and the different infiltration, the different pattern, the different characterization. And actually, this is case, actually it is in front, and this is the back of the liver. And in this case, actually, this is actually diagnosed by biopsy. It is primary hepatic lymphoma. Histological examination of the liver tissue shows that there was significant parenchymal fibrosis. Pathological findings suggesting hepatitis, cirrhosis, and notable hepatocytosis. One could see a large mass in segment 5 and segment 6 measuring 8.5 centimeter plus 7 centimeter, predominantly trabecular configured HCC with histopathological grading of grade 2. Furthermore, the diffuse infiltration of primary hepatic lymphoma in the liver parenchyma was confirmed. You can confirm it, the lymphoma in the liver, primary lymphoma, and superimposed by hepatitis C and develop hepatocellular carcinoma. And this is double malignant tumor in the same organ and same patient. Immunohistological examination was positive reaction for B cell marker confirmed the diagnosis of B cell lymphoma. And you can look here, this is a pattern by CT scan in triphasic and arterial phase, and the same you can see after autopsy. In this case report, we presented a patient with pathological confirmed primary hepatic diffuse large B-cell lymphoma, and on autopsy confirmed the final diagnosis of primary hepatic lymphoma associated with chronic hepatitis C infection superimposed by hepatocellular carcinoma. And thank you for your attention, and I pass conclusion.